Good evening, everyone. I'm Daniel Southern, and tonight I'm going to be talking to you about interventional orthopedics, which is a new field in orthopedic medicine. Let me pull up that and let's get started here. When I began my journey into medicine, I was a 20-year-old. I was a dancer in New York City, and I had low back pain. And I collected $265, and I went to see an orthopedic surgeon. And he was a nice guy, and he tried to help. And I thank my lucky stars. This was in the day before MRI, because I shudder to think what might have happened if an MRI had been ordered and the recommendation for possible surgery had been made, and I might have agreed to such surgery. At any rate, I dodged that bullet. He ordered x-rays, and they were completely unremarkable because I had no fracture in my back. And he pulled out an anatomic model of the spine, and he said, well, it could be a disc, it could be, a couple of things. And I said, well, what do we do about it, doctor? I'm really in a lot of pain and I can't do what I need to do. And he said to me, and I pretty much quote, he said, well, I'm going to give you a back brace to wear. I'm going to prescribe a narcotic for when the pain is really bad. And oh yeah, you got to stop dancing. And I knew immediately that that was not a treatment plan that I could accept. I was paying the rent as a professional dancer. And needless to say, I did not stop dancing. I discovered how to take care of my back pain. I discovered the benefits of stretching the iliopsoas, the bilateral hip flexor muscles. I discovered reflexology. I discovered an old Palmer chiropractor who did an adjustment in my neck called Hole-in-One, which worked very well for me. So decades later, when I went to medical school, I knew a lot about back pain. And I knew a little bit about medicine, the most important being that even a highly trained orthopedic surgeon did not have all the answers. So fast forward again, I finished a fellowship at the Hospital for Special Surgery in Spine and Sports Medicine, and I come out, and now I'm the orthopedic doctor who people are coming to with their back pain and joint pain. And I'm doing the best I can. I'm injecting steroids and more steroids and more steroids. Why? Because that's all insurances pay for when you're doing injections into the spine or into joints. I am doing trigger point injections. I am doing radio frequency ablations of nerves in the cervical, thoracic, and lumbar spine, in the sacroiliac joint, around the knee, around the hip. I'm putting in spinal neuromodulators. I'm doing ganglion blocks, and none of this is working very well. My secretary came back to the office after having her first child, and she had an intractable carpal tunnel syndrome at the wrist with a numb hand. It wouldn't go away, and we injected it with steroids, and it was better for about 2 weeks. And I said to her, well, why don't we try platelet-rich plasma? And I injected the carpal tunnel with that, and it worked. Another employee of the office had intractable left-sided neck pain. We got an MRI, and there was a terrible, terrible looking C2-3 facet joint. And I said, well, let's inject it. And we injected it with steroid, and it was good for about a month. And based on my success with the carpal tunnel syndrome, I said, well, why don't we inject it with the PRP? And we did. And again, it worked. So the first 2 times I experimented with autologous repair cells, I had successes. And that's pretty much what I'm doing today. I'm pioneering a new field of medicine, and it's known as interventional orthopedics. What does that mean? Well, the best way to describe interventional orthopedics is to compare it to traditional orthopedics. And in traditional orthopedics, they're using a lot of tools and they're placing a lot of hardware, and the metaphor is one of carpentry. And interventional orthopedics, we're just using needles through the skin and very advanced imaging to make sure the needle is in exactly the right place. We're just injecting, and what we're injecting is our patient's own blood and cells. we're delivering growth factors to damaged tissues. The metaphor here is one of gardening. In traditional orthopedics, they are removing and rearranging tissues. They are reconstructing tissues. They are replacing native structures. In interventional orthopedics, we are attempting to repair and regrow tissue. We're trying to preserve native structures, and the difference there is key because the design of the human body has been refined over many thousands of years. And whenever you alter that design, whatever you get from that, it comes at a cost. For example, the importance of preserving native tissue can be illustrated by this knee ligament repair. This is the traditional anterior cruciate ligament repair in the knee. First of all, it's not a repair. When the ligament is torn, it is cut out and it is replaced with a cadaveric ligament from a dead person or a harvested ligament from another part of the patient's body. Now, orthopedic surgeons are rightfully extremely proud of this procedure because it gets professional athletes back on the field of play. Unfortunately, we've done it long enough now to know that after doing this operation, within 10 years, the knee is pretty much destroyed from arthritis. And we think that's because the angle of the native ligament cannot be reproduced. Here you see the repair. There's a screw from behind the femur, which is the thigh bone, and a screw in the front of the tibia, which is the leg bone. And the ligament graft is put in at a steep angle. This does not mirror the more horizontal, much shallower angle of the native ligament. So while this repair solves forward and backward translation of the femur on the tibia, it creates a new instability, which we think is a rotational instability, which destroys the knee in about 10 years. Now, here's an article in the New York Times addressing this very issue from the perspective of the adolescent athlete. And the article stated that ACL knee ligament repair in adolescence was soaring. And this Dr. Coker from Brigham and Women's was quoted as saying 50% of these young athletes, and we're talking 15 and 16 years old having this surgery, 50% of them will develop knee arthritis within 10 years. Well, these kids are going to be in their middle 20s. What are you going to do then? And the article ended by saying, will surgical techniques that more closely resemble native anatomy reduce risk? And the answer to that is a resounding yes. And this is why the state of the art of ACL repair in orthopedics today is something called the BEAR procedure, the bridge enhanced ACL repair. And what that is they don't cut out the ligament that's torn any longer. They wrap it in a synthetic tunnel. They inject some human blood in there, and they send the patient to rehab. And what they're trying to do is preserve the native ligament because they've realized that by cutting out and replacing it, they're causing a whole different set of issues, especially in young athletes. So let's go to the traditional treatment algorithm in orthopedics today. It starts with an injury. And acute triage, meaning, you take a couple of ibuprofen, you ice it, you rest it for a little bit, it usually gets better. If not, you go to see a physical therapist somewhere. And that often solves the problem. But when that's not the case, you are typically sent to an orthopedic, and the orthopedic is undoubtedly going to say, well, if you haven't had a steroid injection, let's inject it with steroids. And that may or may not work. And if you go back to the orthopedic at this point, well, he's going to order an MRI. If you're standing in an orthopedic office and you're looking at an MRI, your chances of getting a surgery go up about 90%. And the dirty secret of surgery is that it leads to more surgery, and decades go by and you go back and all they have for you left is total joint replacement. This is the traditional treatment algorithm in orthopedics today. What's wrong with it? Well, let's start with steroids. Steroids are terrible for you. They're toxic, extremely toxic. They kill anything they come in contact with, including the very cells in a knee that's bugging a patient that we're trying to get healthy. The steroids kills them. It kills chondrocytes in cartilage. It kills fibrocytes in ligaments. It kills tenocytes in tendons. It kills osteocytes in bone. This is a study in the Journal of American Medical Association published in 2017. And it was a study that took a number of knees and injected them with steroids every 3 months for 2 years. The control group, because this was a randomized clinical trial with a control group, the control group received an injection of sterile water every 3 months for 2 years. They got MRIs of all the knees before the study began, and they got MRIs of all the knees when the study ended. And what do you think they found? The knees that had gotten steroid injections every 3 months for 2 years had a 50% loss of cartilage. I don't think anything more needs to be said about repeated steroid injections to treat any joint pain anywhere, let alone ligament or tendon tears. It's a bad, bad idea. What's wrong with the current algorithm? Meniscectomy. This is a knee arthroscopy, otherwise known as the let's clean up the arthritis in that knee surgery. The meniscus is a big hunk of cartilage within the knee that cushions the loading forces through the joint. And this procedure is done when there is a tear in the meniscus. And again, this is not a repair of the meniscus. This is a cutting out of this cushioning material, these big hunks of cartilage, until the tear can't be seen anymore. This is a surgery that should not be done. The literature is quite clear on it. And why is that? Well, because I'm quoting just one study here, but numerous studies show that once you have this procedure, your risk of developing arthritis is tripled within 8 years of having the procedure done. And why is that? Well, it seems clear. If you take out the cushioning forces, even if they're torn, they provide less cushioning, and the loading forces in the joint increase, and this rapidly accelerates degeneration in the joint, leading to arthritis. What's wrong with the current algorithm? Joint replacement. And specifically, we're talking again about knee joint replacement. This is not referring to hip replacement, which is a different animal altogether. But knee replacement is a particular problem. It's just not cracked up to what it's supposed to be. Many studies show minimal functional improvement in patients. Only 1 in 20 will achieve normal activity levels after their joint is replaced. Many patients complain of the same or worse pain following the procedure compared to what they had before they had the procedure. And then finally, there's the risk of metal and material fragmentation from the prosthesis that is put in over time, and that leads to a whole mess. So, what is the promise of interventional orthopedics? Well, the promise is that we're using the body's ability to heal itself. All we're using is needles through the skin. It's minimally invasive. There is a fraction of the risk of surgery, and because there's a fraction of the trauma of surgery, it reduces or eliminates operative trauma, and there is minimal or no post-procedure recovery, and there's a very less painful rehab following these procedures. And when we are successful, we are preserving native tissues. And again, there's no need to alter or replicate nature's design because we've effected a repair of the tissue through regrowth in the body. We're preserving native structures. Again, the importance of that cannot be overemphasized. How am I doing that? I am using something called Orthobiologics, and that word comes from using a patient's biological tissue to treat orthopedic injuries. Orthobiologics. What am I using? I am using autologous, which means self, repair tissues from my patients. These are repair cells, and I, as a physician, am simply manipulating them for use in the treatment of musculoskeletal injury. Human repair cells come in 2 forms. One is a small circulating blood cell known as a platelet. So you may have heard of platelet-rich plasma, and that's just a simple blood draw. That's how we get platelets. The other is a stem cell. Now, we didn't know that adult humans even had stem cells 25 years ago. We thought they all disappeared shortly after birth, but that's not true. You have stem cells in every niche in the body. The stem cells that I am concerned with come from your bone marrow. Why? Because studies indicate that bone marrow stem cells have a particular propensity to become the tissues of interest: cartilage, ligaments, tendons, and bone. Here is a schematic just showing that in every joint in the body and in every tissue in the body, there is a balance between forces that degrade those tissues and forces that repair those tissues. And I wanted to use this to illustrate what it is that we are doing. Say you come into my office and you have a very painful shoulder, and we've determined you have a small tear in the rotator cuff. Or let's say you've sprained your knee playing soccer on the weekend, and you've sprained the medial collateral ligament. It's not torn, but it's sprained, and it's stopping you from playing, and you want to get back on the field as quickly as possible. I look at both of these issues and I say, well, I think we can fix that with PRP, platelet-rich plasma. So we do that. What are we doing when we're injecting platelet-rich plasma into the rotator cuff or into the sprained medial collateral ligament of your knee? Well, we're getting a whole host of anti-catabolic, and catabolic means to break down. So we're getting the cytokines, which are cell signaling molecules that work against breakdown. These are anti-catabolic forces, and we get a whole host of them, and they're known by acronyms such as alpha-2 macroglobulin, IRAP, interleukin receptor antagonist protein, TGF-beta, and TIMP, which is tissue inhibitor of metalloproteinases, which along with alpha-2 macroglobulin, these are master inhibitors of a class of enzymes known as proteases. And proteases are these destructive enzymes that are tearing down cartilage in a joint, they're tearing down connective tissue, and these two substances that are found in all human serum, and we didn't even know they were there 15 years ago. We've discovered these very, very recently. They stop these proteases from doing bad things in tissues. IRAP and TGF-beta are powerful chronic anti-inflammatories. So they reduce chronic inflammation in tissues, particularly in joints that are arthritic. And in addition, with PRP, we get at least one very powerful growth hormone known as platelet-derived growth factor. And this is a powerful anabolic force. Anabolism means to build up. And with platelets, you get platelet-derived growth factor. You get a couple of other powerful growth hormones, but the best characterized one is PDGF. Let's assume, however, that you've actually torn your medial collateral ligament, or you've actually badly torn your rotator cuff. And I look at this and I think, well, I can't handle this with platelets. We need to do stem cells. In my world, stem cells means bone marrow aspirate concentrated, BMAC. What are we doing when we do a stem cell procedure? Well, we're getting a whole host of extremely powerful growth hormones. And by doing this work, what we're doing as physicians is we're putting our finger on the scale of this balance between breakdown and build back up. And we're tipping the balance in favor of pro-growth and regeneration in our patients. Now, none of this is done in isolation. I work with a whole host of associated musculoskeletal colleagues, and I rely on them to help me maximize the range of motion in a joint that I'm treating, to address weakness in the dynamic stabilizers of the joint. And of course, dynamic stabilization is muscular stabilization. The dynamic stabilizers of any joint are your muscles. And this is why we send you to physical therapy, to learn therapeutic exercise and get those muscles stronger, because if we can do that, the joint's going to be more stable. I rely on them to work to help me with alignment of joints, and alignment meaning posture for neck and back pain. And what I'm doing in the meantime is I'm working on the laxity of the static stabilizers of any joint. What are the static stabilizers of a joint? Well, these are the ligaments that connect bone to bone, and no amount of exercise can strengthen those. And they are also the tendons that span a joint. And both ligaments and tendons can be made stronger through a technique known as prolotherapy. What is that? Well, prolotherapy is an injection technique. And it, as demonstrated here, this is an ultrasound probe, and this is a needle being placed under that probe. And if you look over here, this is what the ultrasound is showing me. This is the needle coming in. This hard white line is the bone of the thigh, known as the femur. And what I'm injecting is the iliotibial band, which is running down the side of the thigh. Prolotherapy is an injection, and that is defined as a growth factor stimulating injection. And what it addresses is connective tissue insufficiency, something known as CTI. Following any injury, the growth factors in the area of injury are elevated for only a matter of days. And after that, healing is dependent on the maturation of immature repair tissue. And when that is insufficient, if the repair is insufficient, this leads to chronic pain and instability in the joint. So what we're doing when we inject in this technique of prolotherapy, we're raising back the level of growth factors to resume or to initiate repair. What are we injecting? Well, prolotherapy is a technique that's been around about 90 years now. And in the old days, what we used to inject, and what I occasionally do inject now as well, is irritant solutions, sugar water, 12.5% dextrose. It's very irritating. It's quite pro-inflammatory. And when we inject it, it causes cells that are exposed to it to produce growth factors. When you do this work, it thickens ligaments, it thickens tendons, it enlarges the bony area where the ligament and the tendon is inserting. So in other words, it makes ligaments and tendons stronger. So what's the difference between prolotherapy and orthobiologic injection? Well, the only difference is that I'm not injecting sugar water. I'm injecting my patient's repair cells, either platelets or stem cells. So orthobiologic injection can be considered prolotherapy using my patient's repair cells. This is the whole basis of what we do in interventional orthopedics. So let's go back to the traditional algorithm. It's the same in my office up until here because I don't do surgery. If we're looking at an MRI in my office, my hammer is orthobiologic injection. So chances are, if I think you're a good candidate, I'm going to tell you, hey, let's do an orthobiologic injection. I am then going to send you back to physical therapy, and we're going to work on the dynamic stabilizers, your alignment, your range of motion, et cetera, et cetera. And when this whole process is successful, we're getting you back on the field of play, getting you back to doing the things you want to do with less pain, and we have preserved the native tissue or the native joint. We have taken you right out of the algorithm that pushes you towards joint replacement altogether. And I love that. And that's why I practice this new field of medicine. I want to show quickly some examples of interventional orthopedics. This is a knee joint in the OR. This thing is a C-arm that is haloed around this knee. And this is the picture that it's taking. And we'll talk about that in a minute. This down here is an MRI slice through this knee that corresponds to the image that we're seeing on the fluoroscope. This is a C-arm fluoroscope, otherwise known as real-time X-ray. This MRI slice shows why we are doing this procedure. This is the kneecap, known as the patella, and in it is this bright white area, and that shouldn't be there. Bone should be this uniform gray color. This bright white thing is what we call a bone lesion. Why is there a bone lesion in the patella? Well, that's because if you look closely, the cartilage, which is this gray-white stuff back here, is fissuring and breaking up, allowing some of the joint fluid to be pushed into the bone, and it's starting to destroy the bone. So I have to address the bone lesion, and I have to address the fissuring of the cartilage. This shows the setup in the OR. I have drilled into the kneecap with a heavy trocar, which is just a heavy gauge needle, and into the area where this white bone lesion is. And I've placed another needle behind the kneecap, and I've just injected some dye. And this is dark area here is showing the dye. In other words, where the cells will flow when I inject them. And if you look closely, you can see both of those needles right here and here. And this is a bone marrow procedure. I'm going to inject bone marrow into the kneecap, and I'm going to inject bone marrow behind the kneecap over the cartilage to address what is known as anterior compartment knee osteoarthritis. This is an injection of the shoulder to address a superior labral tear. This is a SLAP lesion, superior labrum anterior posterior. This is real-time fluoroscope. This is the picture I'm looking at in the office. And there's two placements of the needle. The first one is into the glenohumeral joint, which is the main joint of the shoulder. And this arcing dark line is the dye I have injected into the glenohumeral joint. The second placement is up here, and you see this triangular area of darkness that the dye is highlighting. Well, that triangle is the superior labrum. And this also is a stem cell procedure. So this shows you how precise we have to be when we're doing this work. This shows how delicate the work can be. This is the hydrodissection of the median nerve at the wrist for carpal tunnel. And this is what I did in my secretary. For scale, this green thing is the size of a green pea. And that's a 30 gauge needle, which is tiny, and it's only an inch long. It looks enormous on the screen, but it's not. Before I conclude and take questions, I'd like to discuss a case report of heel pain. In fact, there are two case reports here, and they're both having to do with pain in the bottom of the foot. This is a 20-year-old soccer player who injured himself. He landed hard on his right heel, and it really hurt, but he finished the game. 4 or 5 days later, he injured it again, and this time it was so bad that he had to stop playing. He showed up in my office, and he was a high school senior at the time who had just got a full 4-year free ride to play soccer at a D1 university. So he was pretty upset. He had 7 out of 10 intensity pain, couldn't even stand on the foot. Needless to say, push off the right foot. He was walking with a pronounced limp. He couldn't run. He couldn't jump. He had to stop playing soccer. For this young athlete, this completely rocked his world. On examination, he was a very healthy young man. He had tenderness on the bottom of his foot by his heel, right in this area right here. The rest of the examination was completely unremarkable. We got an x-ray, and of course it showed no broken bone, so the x-ray was pretty unremarkable. We got an MRI of the foot, and if you look closely, you can see the green arrow sign. This dark thing is the heel bone. This black thing down here is the plantar fascia, and if you follow it over, it comes over, it comes over, it comes over, and up, it stops right there. This black thing should continue over and insert into the bone. You see that there's a little black here, but there's nothing between these two areas of blackness. It's completely torn. This is another view of it. This is looking up at the bottom of the foot. This is the medial band of the plantar fascia, and you see it's not injured. It's inserting into the heel bone, which is this thing here, very well. This is the lateral band, and if you watch it closely, it comes down, and it stops. It does not insert into the bone. This is a view of the same foot from behind. This dark gray thing is the heel bone. This is the medial band of the plantar fascia inserting securely into the bone. This little round thing is pulled away from the bone and flapping in the breeze. That's the lateral band. That's what this guy's problem was. I needed bone marrow for this. We took his bone marrow. I injected the lateral band of the plantar fascia. We put him in a cam walker. We sent him to physical therapy starting at 4 weeks after the procedure. At 8 weeks, we took him out of the boot and started to do some more dynamic work on the foot. The plan was to get a follow-up MRI at week 12. Well, he couldn't wait that long. He was so anxious. He got it at week 11, and this is what it showed. Let me move that. Here's the calcaneus. Here is the lateral band of the plantar fascia. Follow it, follow it, follow it, and it inserts back into the bone. I had to tell you, even I was impressed that it did so this quickly. Here is that look from behind. Here's the medial band of the plantar fascia attached to the bone, and here is the lateral band now attached to the bone. Before, band is flapping in the breeze. After, securely attached. Before, no connection to the bone. After, connected to the bone. He pestered me to play in the last game of his first college season, and I told him it's attached to the bone. It is not yet mature enough to withstand the forces that a young, healthy athlete like yourself is going to put it through. If you play, you'll rip it right off the bone again. Luckily, I convinced him he did not play, but and we got him a redshirt status for the season, and he played a full 4 years on his college team and did very, very well. He was thrilled. I was thrilled, and that's why I do this work. This is another story, very, very similar. A 48-year-old prima ballerina injured the bottom of her right foot, landing hard on it, continued to dance. The injury got worse. She had pain in the heel, pain with pushing off, pain landing jumps. She had to modify her dancing and got to the point where she had to stop. This was a ultrasound view of the plantar fascia. This was the medial band, there is no central band. And I didn't take this. This was done at the time before she came to see me. This is the heel bone, this hard white line. This is the plantar fascia, these white streaks coming off. You see suddenly they end and it looks exploded right here. Well, that's a severe tear. When she came to me, it was now 8 months after this tear, and she wasn't better. And this is the tear immediately, and the plantar fascia in the foot is going this way. When she came to me, I looked at it, and the plantar fascia is going this way, and this is the heel bone of the ultrasound I took. You see, it's very thickened and very cloudy. There is a little bit more organization, but it's still quite pathologic, and she still couldn't dance, and this rocked her world. This was a bone marrow procedure. We treated her starting at 11 months status post the initial injury. We put her in a cam walker. We asked her to cross train. We resumed taking a bar in ballet class about 3 months after we did this. She resumed rehearsal at about 75% speed 20 weeks after we did this. This is the needle treating the plantar fascia. Heel bone, disrupted, exploded plantar fascia, needle delivering bone marrow. And this is what it looked like 20 weeks status post injection of stem cells. This is the right plantar fascia, the repaired ligament. See how much thinner it is and how much more organized it is? It almost looks like the normal plantar fascia on her left foot, which wasn't injured. So you can compare them side by side. They're about the same caliber, almost the same organization. Anyway, she was thrilled because she was dancing again. Initial injury, 20 weeks post stem cell injection. Exploded, gnarly, nothing there, nicely organized. She started rehearsing at 20 weeks. She was performing at 24 weeks. And that concludes my presentation. I'm happy to take any questions. So that was a pretty quick run through. I hope that I delivered the gist, however, of what I'm doing. I'm happy to answer any questions. There are no stupid questions. I'm happy to answer any of them. You have to type the question into the chat, and I will read them out loud and answer them. I got a question from Cliff. What kind of one conditions are you treating? I have knee arthritis. Yeah, I'm treating virtually any joint in the body. My fellowship training at the Hospital for Special Surgery was in spine and sports medicine. So because I was trained in spine as well, there's quite literally not a joint in the body that I don't treat. So I treat all the joints in the neck. I treat all the joints in the thoracic spine. I treat all the joints in the lumbar spine. I treat nerves in the spine. I treat shoulder, elbow, knee, hip, ankle, wrist, finger joints, toe joints. Yeah, what I don't treat, and happens in my office, we get people walking in asking if I do stem cells for Parkinson's disease, for example. And no, we do not do that. We use stem cells only to treat orthopedic conditions. But if you're not a bona fide surgical candidate, or if you are a candidate whom I think I can treat and spare you a surgery, I'll tell you that's where we use bone marrow. We use bone marrow for more severe forms of arthritis. We use bone marrow for torn ligaments that are badly torn, completely torn. We use platelets for less severe forms of arthritis in joints, and we use platelets for less severe, smaller, partial tears in ligaments and in tendons. I hope that answers your question. I got a question from Luther. How does this work with arthritic shoulders? Well, the shoulder is arthritic like any joint, Luther, and it requires an MRI. Before I treat, I usually need an MRI of any joint that I'm about to treat because that gives me the complete picture. I can look at a joint on X-ray in office and on ultrasound in office, and I can see a lot, but an MRI will show me all the tissues. So when I say that we treat arthritis, this is far more than just throwing stem cells into a joint with a single injection and going, there, you've had a stem cell or a platelet procedure. No, that's not the way it works. You have to precisely hit targets. You have to precisely hit the damaged tissue. If you've got a torn ACL on that knee, I got to hit that. If you have a torn medial meniscus, I got to hit that. If you have lax medial and lateral collateral ligaments in the knee, I got to inject those. You have to inject them precisely. So what we're talking about is a bunch of injections done in a single procedure that sometimes takes me as much as an hour. It's a lot of needle sticks. We use anesthetic grade needles. We numb you up. We keep you comfortable, but it's not a single injection. That's not how this works. It's not magic beans. You've got to place stem cells into areas that are injured. Now, when you come to see me, you're paying me for my expertise. Not everybody's a candidate for this. If your joint is gone around the corner and I can't bring it back, and there are criteria for this, I'll tell you that because that's what you're paying me for. If I don't think I can treat it, I will tell you this joint needs to be replaced. So I will give you an honest opinion in that regard. If I think I can help you, I will tell you. I think I can help, and I think this is how I can do it. And then I send you a proposal because your insurance covers none of this. Okay, this is still, we've only been doing this in humans, folks, since 2005. That's the blink of an eye in medicine. So most commercial insurers don't cover this. I do get insurers to pay for it. They are primarily workers' compensation, workers who have injured themselves at work. Workers' comp is a highly motivated insurer because for decades now, they have been hemorrhaging cash with orthopedic surgeries and not getting patients back to work. So they have begun to see that practitioners like myself can treat without surgery and actually get patients back to work. So I get reimbursement from workers' comp. I don't get it from Blue Cross Blue Shield. I don't get it from Aetna. We don't get them from all the rest of the commercial insurers. So I send you a proposal. If I think you're a good candidate, I send you a proposal which lists how much it's going to cost, and you review that in your home. And if you have questions, you call me. I'm happy to discuss, any questions that you have, because you got to be comfortable with what we're doing. But that's how it works in my office. Now, up until that point, if you come into my office, I will see you under your insurance. If you've never had a steroid injection, and I think that you're entitled to one, I'll do one, because that is the standard of treatment in any orthopedic office in the land. And if you haven't had one, I'm happy to do one for you. One. I will not do another. Because if you need another one, I and them going to try to sell you on the better widget that I have, the widget that is better than steroids, which are your repair cells. So, long-winded answer, Luther. I hope that helps. Anonymous asked me, your specialty is mostly sports injury. No. My specialty, my board certification, my primary board is physical medicine and rehabilitation. I have subspecialty certification in sports medicine, spine medicine, and pain medicine. So yeah, I got a lot of board certifications. And when we say sports injury, basically we're just talking injury to joints. That's all. We're not talking about athletes. And I discussed a ballerina and an athlete, but you have to understand that I treat weekend warriors. I treat elderly geriatric patients. I treat children. So I span the spectrum of age here. And just don't let sports injury put you off. If you've got joint pain, I treat it. Linda had a question. What can be done for a disc pressing on a nerve? Excellent question. Tomorrow I'm doing a big lumbar spine procedure where I'm going into the disc. I'm injecting over the nerve. I'm injecting the arthritic joints at that level in the spine, and I'm injecting all the ligaments that hold that level together. It's a very involved procedure. It's going to take me the better part of an hour to do all of this work, but this is to address a large disc protrusion pushing on a nerve. So that's something I treat every day. And it's also something that I hit a home run on primarily because after steroid epidural, there's nothing for you except surgery. And sometimes surgery is warranted. And again, folks, I am happy to tell you if I think that you'd do better off going to surgery. Happy to tell you. But there's a lot of discussion in this regard. And if you come into my office, again, you're paying me for my expertise. I'm happy to share it with you and lay out all the options for you, including surgery, and tell you the pros and cons of each. Because if I find that if I have a fully educated patient, they can make the best decision for them. And that really builds trust between me and my patients. Now, quite often I'd like you to do an orthobiologic injection, but it's you. It's your problem. You make the final choice. Can you speak to cervical disc disease and effectiveness? Yeah, cervical disc disease is not something I've treated since I was full bore practicing pain medicine. 15, almost 20 years ago now. And back then I did it maybe a handful of times. Cervical discs are not nearly as much of an issue as lumbar spine discs. Why? Because the forces in the cervical spine are a fraction of what the forces are in the lumbar spine, which is in your lower back. So no, I do not routinely treat cervical discs, and that's not typically what we're treating in the neck. What we're treating in the neck is instability, where bones come close together, and as they do so, they begin to slip and slide. We're treating stenosis in the neck. We're treating nerves that are being pinched in the neck. We're treating neck instability. So quite often I'm doing that. I can't tell you the last time I injected a cervical disc. But I don't know where you got that idea that that's your issue. I'm happy to look at your MRI and give you an opinion. I hope that answers the question. Let's see. Anonymous has lots of questions, or maybe it's another anonymous. Did you say you inject bone marrow into the knee? Yes, I inject bone marrow into any joint. In fact, I inject bone marrow inside the joint. I inject bone marrow into ligaments and tendons of the joint. I inject the bone on either side of the joint. That's called bone augmentation. So yeah, the only thing we don't inject with bone marrow, I never inject bone marrow into the epidural space. I think that would be a really dangerous and dumb thing to do. And if somebody tells you they're going to do that, think twice. Otherwise, yeah, we use bone marrow for any other structure. I received a PFR or my knee and was in a lot of pain afterwards. I have osteoarthritis. Took over 6 months to feel better. I received a PFR. I don't know what a PFR is. Platelet fibrinogen-rich platelet. I'm guessing that's what it is, Anonymous, that you're asking me. Yeah, fibrinogen. My mentor at HSS got into fibrinogen for a bit. Studies really haven't been terribly persuasive that that's a thing or that it's really, really helpful. And depending on who did it and where you did it, your PRP, your platelet fibrinogen rich, may have been contaminated with a lot of blood. Let me, quick side note on that. PRP is not PRP, okay? PRP in my office is highly pure, meaning that we work very carefully to make sure that it has little to no red blood cells in it, because red blood cells are not good for your joint. Ask any sickle cell person that bleed into their joint. Red blood cells tear up a joint, so you don't want them there. And that's quite often the source of tremendous pain, is when you're getting a PRP injection that is contaminated with a lot of red blood cells. So you might have had a lot of pain from a PRP injection that wasn't very pure. And I don't do fibrinogen. I would if the studies were there, if I thought that it could help my patients. I don't do that. We do platelet-rich plasma. Another form of your platelets that I often use, particularly in the spine and around nerves, is something called platelet lysate. That's where we take your platelets, these tiny little cells, whole cells, and we freeze them, and then we quickly thaw them. And what that does to the cell is it disintegrates it. And what I'm left with is a soup of the contents of your platelets. And that's a smart thing because inside these tiny little cells are all the powerful repair hormones and repair cytokines that the platelet secretes. And when I inject platelet lysate, I'm delivering all of that all at once. So that's another form of platelets that we use. And of course, we use only what we get from our patients. We don't use anything else in this office. Let's see. Looks like Clifford had another question. Where are you located? Yeah, I'm sorry. I was so ill prepared for this evening, and that's because of technical difficulties. I am located, my practice is located in Norwalk, Connecticut. And if you Google me, I'll pop right up, and you'll have the address and the phone number and et cetera, et cetera. 91 East Avenue, Suite 1A, Norwalk, Connecticut, 06851. That is the address. Next question. Let's see. Anonymous again. Thank you. Well, thank you, Anonymous. I appreciate your attending. I appreciate everybody's attending. Are there any more questions? If you have any questions, I'm happy to answer them. 9 questions so far, and I think I answered all of them. Looks like I did. I'll wait a few minutes. I'm in no rush. Are there any other questions? Yeah, looks like one more question. Anonymous. So not covered by insurance. When we do these procedures, no, it's not covered by insurance. There are some insurances that are beginning to cover PRP injections, but they have no idea what I'm doing and the involved nature of it. But I have heard stories. A couple of my patients have gotten some reimbursement. But no, this is the kind of thing that, you vet at home. I send you a proposal with the cost of, there's no surprise. It's not, you'll know exactly what it is. And it's the kind of thing that you put on a credit card. That's how typically you finance this. We used to offer financing. Nobody took advantage of it. And it was a terrible, terrible deal, I have to tell you. You ended up paying a lot more in interest, a lot more. And nobody took advantage of it. So, basically it's cash in the barrelhead, and we do give a discount for cash procedures, but insurances don't cover this. So, like I say, how it works in my office is I'll treat you under your insurance for as far as it goes. If you're not responding to physical therapy, to electroshock wave therapy, to time, to analgesic medications, ice, rest, even a steroid injection, like I said, I'll do one of those. If you don't respond to any of that, then you're at a crossroads, and I'll happy to explain what your options are. And one of them is going to be an orthobiologic injection. But you don't have to pay me cash to come see me. We'll see you under your insurance. That's how that works. People wander into my office all the time. They have no idea what I do. They see orthopedics in the name. They think I'm an orthopedic. They come in, they pick out their insurance card, and they pay this, they use their insurance to see me. And I'm fine with that. We only go to cash when we're at a crossroads where we're looking at, do we go to surgery or do we try an orthobiologic injection? And I'm the one who sort of determines whether you're a good candidate for orthobiologic injection. And if I think you are, then I'll explain it to you, and then I'll send you a proposal. That's the model we use in my office. A couple more questions, it looks like. Do you take Medicare? Yes, as I explained. Yeah, we take whatever your insurance is. We'll see you under Medicare. Medicare is not going to pay for an orthobiologic injection, but I'll evaluate you under Medicare. I'll order an MRI under Medicare, and I'll review it under Medicare with you. It's only when, if I determine that you're possibly a good candidate for orthobiologics, I send you a proposal. It's only at that point. If you agree to go forward, then you've got to pay me cash to do the procedure. Is that clear? Cliff had a question. For knee meniscus treatment, typically how long is the treatment recovery generally? That's a good question. It depends on whether we're using bone marrow or we're using platelets, Cliff. We get a quicker recovery with and how bad the tear is, and that determines whether we're using platelets or whether we're using bone marrow. And by the way, whenever we do a bone marrow procedure, a stem cell procedure, we're always doing a platelet procedure along with that. So you get platelets with the bone marrow. If I feel I need the stem cells, I'll tell you that. But if not, we're using just platelets. Now, with platelets, recovery time, we expect that you're stiff and sore after a platelet procedure, 3 to 5 days. Bone marrow, depending on what we're doing, maybe a little longer, maybe a week to a week and a half. And then you're back to your baseline, which is really kind of the pain and discomfort, stiffness that you had before we did the procedure. And then we're waiting for takeoff. Takeoff, when does that occur? That's an excellent question. Again, recovery and results begin much quicker with platelets. But even with a platelet procedure, I won't pass judgment on a platelet procedure for a minimum of 6 to 8 weeks after I do that procedure, because it takes that long. Tissue change is what we're trying to stimulate. Tissue change. Tissue change takes time, okay? Tissue change begins a couple of weeks after we do one of these procedures. So you got to give it time. So you need to keep that in mind. You got to have some patience. Well, with a bone marrow procedure, it's much longer. The largest database that we have of outcomes from doing stem cell procedures indicates that on average, the first blip up in the data, that means pain is decreasing, function is increasing, occurs between 8 and 12 weeks after a stem cell procedure. And I won't pass judgment on a stem cell procedure 5 to 6 months. So you're looking at a long throw to, are we going to get a response? Now, if I'm doing a stem cell procedure and I don't get any response at 3 months, I'm thinking maybe we need to do a booster of platelets, because quite often that will get things back on track. So there's nuances to this. I hope that answers your question, Cliff. But the recovery is brief. It's a fraction of surgery, quite literally. For knee meniscus, do you take Medicare? I think I answered that. All right. Yeah. Good questions, folks. I appreciate it. So we've had 12 questions so far, and I think I've answered all of them. Again, I'm happy to wait another couple of minutes and see if anybody has any more. Anything that occurs to you? As you may have been able to tell, this is my passion. By rights should be retired by now. I'm not, because I've spent over a decade acquiring these skills, and I continue to help patients. And like the 2 case reports I showed you tonight, I could go on showing you case reports, neck, the back, the knee, shoulder, hips. It thrills me when I'm able to help a patient. So that's what keeps me going. That's why I continue to practice. So again, the name of the practice is Interventional Orthopedics CT. We are located in Norwalk, Connecticut. You can Google Southern MD, Daniel Southern MD, Interventional Orthopedics CT, and you'll find me. Give us a call. Come on in and see me. I'm happy to give you an opinion. Looks like we have one more question. So you treat stenosis, but not herniated discs. Just got an MRI that shows borderline. I don't know borderline what, but I treat herniated discs. I treat stenosis. It depends on where you are and what you've been treated with. If you haven't had a steroid epidural, I'm happy to do one of those for you to start and see how well you do. I'll do one steroid epidural, because sometimes you do one and man, I'm telling you, it works like gangbusters for months. I've done them in some people where it's worked for almost a year and more. So you're entitled to that, and I'm happy to do that. So come see me. Bring your MRI. We'll take a look. I'll give you an opinion of whether of what I would do in terms of treatment, and whether if you're ready for an orthobiologic treatment, whether I think you're a good candidate for it. look, there's forms of arthritis that I can't treat, and I'll tell you that. There are forms of stenosis that I'm happy to try and treat, but I'll tell you right up front, the likelihood of success is not good here. Stenosis, I've got to get you at earlier stages of stenosis. But severe critical stenosis, if you can't walk more than a block or half a block, you need surgery. And I'll tell you that. Happy to tell you that. We don't work miracles here, folks. That's not what we do. This is not magic beans that, treat anything. No. There's criteria that I've learned that help to guide me when I advise a patient whether they're a good candidate or not. But yes, we treat stenosis and we treat herniated discs. Absolutely, we do. All right, 7 o'clock. We've been at this for a little over an hour. Final questions, anybody? So anonymous clarified. Borderline compromise of central canal. Oh, all right. Well, that's mild stenosis. We treat that every day of the week, and we do very well with it, Mr. Anonymous or Mrs. Anonymous. One final question here. How many years in practice would you say you do volume of patients? I do a lot of patients. This is all I do, folks. Okay. I've been in practice since 2004. So what is that? That's 22 years now. I've been doing this work exclusively for 6 or 7 years. I've been doing this work for over a decade. I've been doing it exclusively, nothing else but this work for 6 or 7 years now. And when I say nothing else, I don't, I used to do, like I said at the beginning of the lecture, tons of steroid injections again and again and again before I knew better. I used to burn nerves out. I used to do very destructive things in the body. I don't believe in that anymore. I just don't believe in it. It never worked anyway. If it worked great, I might have been able to overlook it. I couldn't overlook it, and it didn't work great. So I don't do any of that stuff anymore. Volume of patients. Oh, gosh. I'll do half a dozen bone marrow cases in a month. I'll do 3 times that PRP in a month. Busy months, even more. We're doing procedures pretty much every day of the week. I did 2 this morning. I did 2 yesterday. We do this a lot, folks. We do this a lot. A lot of experience here. Looks like a couple more questions. All right, you guys aren't going to let me go. Let's see. Oh, no. Okay. How many years in practice? Would you say you do volume of patients? Yeah, I'd say I do volume, but this is not a factory. We don't, let's see. Okay, Lorraine had a question here. Discharge to home after correct. The procedures are done in my office, folks. I used to do them in a surgery center. I wasn't happy with the outcomes there. They didn't know what I was doing. There's a lot of pressure to speed it up, to go quicker, and I didn't like that. So I don't do them there anymore. All procedures are done in my office, in my procedure suite. We give you a private room of your own to prepare for the procedure and to recover in. And when you're ready, we discharge you to home. You have to have a driver who takes you home. I have people who come from out of town. Luckily, my practice shares a parking lot with a very nice hotel. And patients come down and check into the hotel, and they stroll across the parking lot in the morning of their procedure, and they have a procedure done. And if they're smart, they stroll back across the parking lot, or we wheel them back across the parking lot in a wheelchair up to their room, and they spend the night before they jump in a car and drive home. So that's how that works. Yeah. Okay. Looks like, let's see. Any more questions? Final questions, folks. They've been great questions, and I've enjoyed myself, and I hope you have. I hope you learned a couple of things about what we do. And I hope that it, stimulates your interest enough to say, hey, I'm going to go talk to that guy, see what he has to say. Because really, it's my pleasure. You're paying me for my expertise. Before I stop practicing medicine, I want to use that expertise. And I'm happy to tell you and give you an opinion. of whether I think I can help you, A, and what your chances are. We put people into 3 buckets, basically: good, fair, poor. And just roughly, the good bucket is we think that you have a 60% chance of success, however you define it. So 60%. If you're a fair candidate, we think your chances lie somewhere between 30 and 60%. And if you're a poor candidate, we think your chances are probably less than 30%. To say that another way, we think that every 10 times we try this procedure in you, a poor candidate, we're probably going to fail 7 times. We might have success in a couple of patients, less than 3. We expect to fail 7 out of 10 times. Those aren't good odds, which is interesting because I have done these procedures on patients who I've told, I think you're a poor candidate, and I have had successes. In fact, I can do a lecture on virtually every joint in the body where I told somebody I thought they were a poor candidate, and they decided, I don't care, doc, I want to try this anyway. We did the procedure anyway, and they had a good outcome that they were happy with. So there's exceptions to all rules, but I'm happy to tell you right up front. And if I think that the joint needs to be replaced, I'll tell you that too. Okay. That's it. I think that's it, folks. Yeah, well, you've been a pleasure. I've enjoyed myself. I hope you have. Thank you so much for coming out. I appreciate it. I thank you again.